Thank you so much. Congratulations to the program committee, and particularly for the local organizers, Rachel and Josephine. It's great to be here in Oslo. It's my first time here. This is a long title, but really what I want to share with you is just a clinical observation I've made about enhanced S-cone syndrome in my practice over the last year. So this is the typical patient that comes in that will end up having enhanced S-cone syndrome in my clinic. A young child, poor night vision, reduced vision that doesn't fully correct to 20/20, typically with esotropia that straightens with hyperopic correction. When I see someone presenting like this, in my experience, already I'm suspecting enhanced S-cone syndrome. And then when you look at the retina, it's very, very suggestive also. You have these hypopigmented lesions along the arcades. The disc looks okay. The vessels look pretty normal. There's a foveal schisis in the center. This really is very, very suggestive in the context of that presentation of enhanced S-cone syndrome. Another child, very similar presentation. It's a recurrent phenotype. Sometimes they come in with some retinal fibrosis. It can be more extensive. Adults classically have these nummular pigmentations around the arcades, and also the foveal schisis. We know the enhanced S-cone syndrome is related to biallelic mutations in NR2E3. Typically, sometimes it's related to mutations in NRL, which is in the same pathway. They have absent night vision, and again, they have a very characteristic retinal appearance. But what really makes the diagnosis is the pathognomonic ERG. The ERG is pathognomonic when it's recordable. And the pathognomonic ERG shows no rod response, a dull and delayed response to the flash scotopic. The cone response, the photopic response, is very similar to the photopic flash response, and the flicker is delayed and depressed with the A wave being, with the flicker amplitude being less than the cone A wave. This is the pathognomonic ERG of enhanced S-cone syndrome. Now, an electronegative waveform is not part of the pathognomonic ERG for the enhanced S-cone syndrome. However, I've noticed at least one patient with enhanced S-cone syndrome in the United Arab Emirates who had an electronegative ERG. So that stimulated me to look more into the makeup of enhanced S-cone syndrome in my patient population. And so this presentation is a retrospective review of patients diagnosed with enhanced S-cone syndrome who had ERGs and who had genetic testing, and identified 10 children from 6 different families. Only one of them was homozygous for NR2E3. The other 9 were homozygous for the same NRL variant, and I didn't realize this until I went back and looked at it. ERGs were done in 7 children, 4 families. 6 were electronegative. All 6 were homozygous for the NRL variant. The one ERG that was not electronegative was in the patient who had the NR2E3 mutation. So this is a summary. Because of time, I'm not going to go through the features, but I summarized already what we saw in these patients. Here's a sample ERG with the normal on the bottom. You can look at the middle tracing. It shows you the electronegative waveform nicely in the middle vertical tracing. Again, the top is the patient. The bottom is a normal waveform. So when I looked at the literature, I looked for patients, when I looked at patients with NR2E3 mutations who had ERGs published, I couldn't find any with a documented electronegative ERG. Then I looked for the NRL cases, and I found 8 published NRL cases with documented ERG findings other than non-recordable. And not all of them were electronegative, but 5 of them were, 5 out of 8. So it seems to be a recurrent feature of NRL mutation. In addition to these cases, there was another patient reported who had NRL-related enhanced S-cone syndrome. The ERG was not provided in the report, but they mentioned that the ERG had a decreased B to A wave ratio. So to summarize, what I'm trying to tell you here is that NRL3-related enhanced S-cone syndrome is more common in the UAE. When you look throughout the world, it's typically NR2E3 mutations, but it's predominantly NRL in the Emirates, and it seems to be related to a founder variant. The associated ERG with these patients is electronegative. Every single patient who had this mutation who we tested had an electronegative ERG. And my second point is an electronegative ERG seems to be a recurrent feature of NR-related enhanced S cone syndrome. Previously, there's been no documented clinical way to distinguish NR2E3-related enhanced S cone syndrome from NRL-related enhanced S cone syndrome, but this might be a way to do it. So, thank you for your attention.